2023 SEOW meeting, and the agenda is before you, and our focus today is going to be first our wellness program recommendations, and then we're going to be talking about benefit design for medical, dental, and vision. So you see the agenda. We're hoping to end at 11:45 to get the board members a little bit of time before they have to start up again at 12:30. The only additional thing, there's not a break in this. I will try to find a time for a break. I'm hoping maybe after Kirsten and I will kind of work through that, and we'll find the right time for a 10-minute break. So with that, the first, and Robert, you may not have been on when I said this a little earlier. Jeff is going to join us a half an hour late, and Ali is off at an Oregon Health Policy Board meeting this morning, so he will not be with us. But the rest of the OEB staff, including Damien, is on board. So with that, there's the December meeting synopsis. Any questions or concerns? Otherwise, I'll accept a motion to approve.
Motion to approve.
All in favor?
Aye.
Aye. Aye. Okay, so on we go. Kirsten, you're going to take us through the wellness program overview. And
hi, Tom. Actually, oh, go ahead.
Our goal here is to be able to give a recommendation to the board. Is that correct for today?
That's correct. And my colleague, John Kessler, is actually going to walk everybody through the wellness overview.
Okay, great, John. Go ahead.
Good morning. Can everybody hear me?
I can.
Okay, excellent. So thanks again for the opportunity to talk on wellness today. We do have a lot of material to cover, and we'll try to get through it quickly and make sure that we get to leave plenty of time for this group to discuss the programs and the recommendations to the board. So we'll start off with some overall observations. So as part of the renewal process, we took this opportunity to briefly review the current wellness programs, in terms of member engagement, costs, and outcomes. We wouldn't characterize this as a formal assessment, but it really is a kind of a first look at what are these programs doing, what are their costs, and things such as that. So we'll start with some overall observations, and we'll take a deeper dive into each of the programs. So in terms of Weight Watchers, there's pretty good, subscribed, 8% of members are subscribed, eligible members are subscribed. However, that doesn't mean those people are active, as we'll see later on. And also considering the program tenure, it might be time to revisit, that program and see what else is in the market. In terms of WebMD, the current structure is not really leading to much engagement, and it's again something that probably needs to be revisited. Again, we'll go through some details as to how we get to that conclusion. There are two new pre-diabetes program. These are one from Kaiser and one from Moda. And these are both really kind of bright spots, I would say, in terms of, again, a little early since they both were just implemented in the fall, but, definitely in terms of their structure and how they approach, things are definitely probably a good model for going forward. And again, we touch upon, two other programs as well. Both Kaiser and Moda have grant programs that help out the entities directly. And in addition, Moda has a program of wellness advisors to the entities as well. So our overall thoughts are it probably is worth proceeding with a more formal assessment of the current wellness programs and really thinking about developing a comprehensive wellness strategy and goals. to really understand, what does the board want to accomplish in terms of wellness for the OED members. So, and again, that's where we came out on this.
John?
Yes.
About 4 years ago, we did that kind of deep dive into wellness programs with Willis Towers Watson. And I don't know whether or not Mercer has seen that effort. I agree with you totally that it's time for us to look at again, but it'd be interesting to use as a starting point what we did in 2018-19.
Yeah, exactly. I think that's really helpful. I think we want to make sure that we do see that and use that as a starting point, because again, we're not starting from scratch here. I think that's a very important point.
Yeah. And Glenn, maybe you can resurrect that and get it to the Mercer team.
Will do, Tom.
Okay, thank you.
Thank you.
Sorry for the interruption.
No, I appreciate the interruption, Tom, and feel free to do so, throughout the, if there are things to add. Again, I'm, fairly new, and so just, glad to learn. Okay, moving on to the next slide, and this is really just providing, some highlights of, what's going on. And, so it tells you, when it was implemented. As you can see, Weight Watchers has been around the longest time, followed by WebMD. And the pre-diabetes programs, are both fairly new, as you can see, implemented in the fall, and then the wellness grants and advisors, in the 2018-19 period, and so this is how we're thinking about this, is really looking at, tenure, how long has the program been around, engagement, how many members are engaged. I think the important thing there, as we'll find out, is really, what does engagement mean? And what is active engagement? The other thing is pricing approach. As you can see, there are a couple different flavors of that. With Weight Watchers, it's just a fixed amount. With WebMD, it's 25 cents per member per month. And then if you look at the pre-diabetes program, it's per participant. And then the grant programs are really, fixed amount that the board has approved. Just a quick thought on that. I think the preference is really to, where it makes sense to really do something on a per participant basis, so you're paying for people who are actively engaged in those programs. Let's see what else. I think the other thing too, that we have this row around value as well. As for many of these programs, it is not easily assessed. Especially so clearly for the the grant programs, it's difficult to assess because it's not really having a member level impact. It's really having an impact on the entities, and and we're the first to acknowledge that that there are values to there are values that wellness has values, both in terms of making people healthier, but also there's also an employee relations value that you might see from the grant programs and such. The questionable for WebMD, and we'll get into that a little bit more when we get there, is really it's really difficult to discern the impact that program is having on members. And on the Weight Watchers, I think it's also not easily assessed because it's kind of difficult to understand what the outcomes are and if they're meaningful. And again, for the new diabetes prevention programs, not easily assessed is because I'm sorry, it's TBD because those are too new. So let me just pause there and see if there are any questions or comments.
Yeah,
this is Bill.
Yeah. Go ahead, Bill.
I noticed in our district, Weight Watchers was doing pretty good, quite well, but what it required, it fell apart when it lost its champion, like the person who organized the group, and it was very team oriented. If you didn't have a team, it kind of fizzled. That's all I'll say about our personal district's history on Weight Watchers.
Actually, that's a very good thing to highlight, Bill, because I think in a lot of these wellness programs, some of the strength comes from doing this in community. And you'll see that in some of the new diabetes prevention programs as well, that's a kind of a key component, that I think things work better when people do them in a community type thing. Let's dive into it just in the interest of time. So Weight Watchers, the structure that we have for each of these is really a brief program overview. Then we go into an engagement summary, member outcomes, and just to be clear, there are not always member outcomes. Sometimes these outcomes are more at the entity level, and then some key takeaways and observations. And this is really information that we're providing to this committee to help them determine what recommendation to make to the board. So in terms of Weight Watchers, as you can see, it's really a science-based weight management program. The purchases, the OEB has purchased both, has the premium offering. So the thing is, this provides access to the online tools, which include the science-based nutrition, the point system, and then also with the premium piece, they have that coach-led workshops and things such as that. And that community. And as Bill had already highlighted, communities is really kind of a key, I think it's being accountable to one another is actually a good way of moving things along in terms of making behavior change. The other thing too, that I wanted to mention at the beginning of this whole conversation really is how wellness is very much aligned with this shift left. That was one of the additional goals that was identified by the board in the retreat, and this is kind of a key component of that. The other piece of this to remember, I think, is from some of the retreat information is that kind of health production function, and if you think about it, 30% of health, according to the WHO, World Health Organization, is really based on our behavior. And this is really what wellness is trying to change. And for context, 10% is 10% of our health is related to clinical care itself. So let's just continue on. So I think what you definitely see some challenges here. I think very concerning is this decrease in newly subscribed members. We're seeing a 38% drop, which is much higher than the Weight Watchers benchmark. The 8% of subscribe, eligible members being subscribed is a little bit ahead of benchmark, but again, I think this does not represent actively engaged members. That's about half of that is actively engaged members, a little over half. Member tenure, generally a good thing, but if this is just being subscribed and not really using it, maybe not so meaningful. One of the key outcome measures here is subscribed members who lost over 3% of their weight, and that's behind the benchmark. We will also kind of highlight some other things that are of interest because it probably presents opportunities. Is really you see a more female heavy mix in terms of participants and also employees. So this is probably an opportunity in terms of targeting greater involvement in this as well. Okay, moving along. And here's where we're looking at the member outcomes. And again, this is really the subset of members that are more actively engaged, because in order to be able to make some of these measurements, you have to have weights for people beginning and ending during the year. So 95% of members improved or stay in a healthy BMI category, or maintained their weight. So essentially either maintained or had an improvement, and that's in line with the benchmark for Weight Watchers. The other thing to really highlight here a little bit is the 75% member satisfaction, which is not great in the context of the broader wellness industry. Typically, the targets there are around 90%. And then in terms of program cost, again, as we mentioned earlier, this is a flat amount, hasn't been changing. And, for context, we provided some standardized measures here. And as you can see, and this is really looking at per subscribed member per month is, $14.32. Since they highlighted it, the cost per pound, we just put it in there. It's $231 per pound lost. Yeah, and again, not sure that how helpful this is, but it just provides some context. I think the real challenge is that how many times you're paying for that same to lose that same pound is part of the challenge. Is because I think everybody knows that in weight loss, one of the key challenges is once you have lost the weight, is keeping it off. Okay, now some observations that we'd like to bring to this group. Again, we briefly mentioned the mixes, that there's opportunities probably to increase the participation by males and spouses. And we talked about some of the key challenges of the weight loss. And again, what you see in the metric that Weight Watchers use is really, I think that there are better ones out there, and that's really something that would be maybe more of a 5% loss and then sustained over 12 months is what you're seeing more commonly going forward now. We talked about the satisfaction. 75% is not a particularly good outcome. And so I guess there's some question whether these funds could be better used elsewhere. And are there other programs that are that weren't available when this was first implemented that are available now that would speak to a broader array of broader range of your population? So again, considering that there is this engagement of the subscribers of 8%, if you were going to discontinue this or change it, that whole member relations aspect needs to be taken into account.
So Kirsten and John, I would like to see if we could spend 5 minutes now to kind of come to our recommendations on WW, as compared to going through all the other ones and then trying to recycle it.
I think that's a great idea.
And this is obviously our biggest wellness intervention. And I think you highlighted both the positives and the negatives. The positives is that we have 8% of our adult population doing this. The price has been stable. The downside is efficacy and some decrease in satisfaction and some decrease in new engagement. So what comes to me as in terms of a recommendation would be saying continuing this program for next year, but during the year deal with what you're talking about. Number one, are there better solutions out there? We all hear things like Noom and other ones. So we need to know what's their costs, what's their efficacy, and how would one transition from WW to something different or continuing with WW. But I would propose that we spend the next year looking at that. I'm interested in Bill and Robert's thoughts in this regard.
So I'm fine with that recommendation. I just don't know what the alternatives really are. So it'd be good to know that before we make a more final decision. With trends on sorry, I don't know how to phrase it. So with trends on attitudes on weight loss, maybe not being I'm going to stop. I don't know exactly how to phrase it. I'll figure it out some other time. I'm not going to have you wait on my old man brain to work. So
Okay.
I'm fine with the recommendation. I think we need to see alternatives.
Okay. Bill.
For
Okay,
me,
Bill.
Kirsten.
No, Bill, please, and then I'll go after.
I'm kind of on a different train track here, kind of looking at the bigger picture. And I also don't have the correct words, but I know what I'm thinking. That, I look at these metrics and they're like current or short-term metrics, which is fine. And I can see the problems that these short-term metrics, but I'm kind of wanting to look at the longer-term metrics, which is like if these people who are on, and I'll just say these kind of prevention programs, which includes diabetes, are they our higher consumers of funds, where smaller percentage of people, but larger percentage of funds. The thing that popped in my head, which is kind of morbid, but I don't have a better way of explaining it, is, so for example, for me who lived in the South, and when we have hurricanes come through, you can count the number of people that were directly impacted at the time of the hurricane, which is a valid number. But you're also wanting to count in people who couldn't get medical attention, hospitals were closed, people who died of unrelated illnesses, but they couldn't get to what they needed. So you look at instead the average number of deaths during and post the hurricane compared to the same period in previous years to see what the difference was, to see how that hurricane affected in other ways. If we're reducing our costs with these people somehow, when we can see that, because these are higher affected people, be it diabetes or obesity or whatever, then that is not playing into these numbers that are just short-term, quick effect numbers. I'm looking for the longer-term effects. Hey, I don't know if I explained myself well or not, but that's kind of my.
You're right. I think you're right on. Is are we affecting the long-term health of the population by offering programs like this, and with that, also the economic component of it, of by having these interventions, does it decrease costs later? That is a very, very complex study. And for the Mercer team, we asked about 4 years ago Kaiser Permanente to look at their population who were in Weight Watchers at that time. And I don't think they'd moved to WW. And there was a small impact. I think it was like 1 out of 6 had a 5% loss of body weight. So there was something there, but it was again, it was not easy to study. So addressing the issue, Bill, that you're raising of long-term effect, multifactorial, really difficult, but it's really where it matters. Kirsten,
so kind of
go ahead.
So I was just to emphasize the point that, if these 8% are in our top 15% of high risk, that's more the ratio that matters than this total population percentage participating.
Got it. Yeah. Agreed.
Okay, I'm done.
But it sounds like you're okay with the recommendation of continuing it for this next plan year, with the idea of following Mercer's recommendation to see what else is out there and do what's necessary over the next year.
That'd be true, because I'm making the assumption that the people who are participating in this are in our higher risk categories.
Yeah. Okay, Kirsten.
That's great. I think that sounds like a good recommendation. I do. It's unfortunate we can't have all the presentations all at the same time. So I will just borrow from a future presentation and let you know that and maybe Robert, this is what you were trying to say, maybe as many as 30% of the members within OEB's population are struggling with obesity. And when we were digging into the different treatment options and point solutions available to people, it just became really clear to us. We have Weight Watchers all the way on one end of the spectrum, bariatric surgery all the way on the other end. And then for people who because you can be overweight and not necessarily be at high risk for diabetes, which would rule you out from the diabetes prevention programs. For people struggling with obesity in the middle, we really don't have a lot of options. And so we're going to see in a later presentation this morning at SEOW some ideas for beginning to fill in that gap. And I think, with the Weight Watchers and the renewal that we're having this year, in my mind, it's certainly targeting weight loss is really important. I think I had the question, is that the right best highest impact place to spend $1.4 million this plan year? Is there a different way to impact weight loss, maybe with a higher impact using that money? Certainly having it on the agenda for 10/1/24, this idea of, okay, let's spend the next year and do all of these studies that Bill brought up, look at the members, pre and post weight loss program, understand, is 3% weight loss target? That's Weight Watchers metric for success. Is 3% body weight target loss enough to materially impact chronic conditions over the long run? Fortunately, OAB's population is so stable. It's perfect for that kind of thing. We can take a look at it. But yeah, I do just have the question because it's a tough financial renewal this year. We'll have to be really, really thoughtful about what we do, if there might be a higher impact spot for that 1.4 million.
The only thing that I'm going to add to that issue around rates, my understanding is that we're paying for it through the administrative fee component. So we can confirm that. We're running, as usual, this is a good conversation and we're running low on time. So your point is well taken, Kirsten. The idea of making a change, we don't have time to do the in-depth study to find out what is the right, if there's something better. And
Yeah.
that's the reason that I think we need to go with for the next year, but to actively look at it and let WW know what we're about too.
Yeah.
Yeah. Okay, so I'm getting a note from Erica that it's actually paid through claims. Okay, I thought it was funded through the administrative fund, but that shows how much I know. Okay, let's move on, because the WebMD is the next one I think we're going to talk about, and that's where, just for your information, again, Mercer, you're new to our conversation. We thought that we were very disappointed with WebMD's engagement last round, and we said this year, let's see what they could do to ramp up. But I'm going to call it, they were on a pretty short leash. So with that, that's the history from last year that you two wouldn't have seen.
Hey, Tom, can I break in real quick? And maybe this is more of an OEB discussion. So if we're thinking about keeping Weight Watchers on for another year and reassessing, then maybe this is an opportunity to use some of our reserves, using the one-time reserves to pay for a one-time extension. So maybe that's an alternative.
Okay.
Because as you know, we don't want to use the reserve for ongoing things, but this might be a more, 1 point whatever million might be the right way to go. Oh, sorry.
Okay. So moving on to WebMD. Again, this is really, a platform that is, supporting members and tools and resources to help them support their health. A lot of online things around daily habits, monitoring. Also, there's a lot of online content and trackers and things such as that. So that, and then let's just keep moving on. I think people understand what WebMD offers. What you've seen is pretty limited use. I would say, essentially, if you look over all of the metrics that they provided, it's really, less than 1% of eligible members have engaged with the platform. Um, I think the other thing that's concerning is really looking at that decrease in new platform registrations and also webinar attendees. And I think part of the challenge is that this organization has gone through several changes in platform over the last couple of years as there's been consolidation in the wellness space. I think your original vendor was bought out by SEOW, which was bought out by WebMD. With those platform changes. Again, that you can see the top 5 products that people use in terms of the health record, the challenges, and things such as that. Moving along, member outcomes, really hard to determine. Again, there's been limited use, which is positive, that there is some use, but who knows what's happening in terms of whether the lifestyle behavior changes are taking place, and really not really any measurable member level outcomes. So it's really, WebMD is more tracking participation than health impact here. Moving along to program cost again. This is 25 cents per member per month. And then what we tried to do is provide some standardized metrics just to kind of help you understand what you're getting for that. So it's about $1,200 per new platform registration, $600 per webinar attendee, and about $700 per newsletter subscriber. And again, this PMPM approach to pricing, not necessarily preferred, because you're paying for everybody to get everybody in your population, regardless of whether they're engaging with the platform. And again, the challenge here is that those numbers don't look particularly favorable when there's a lot of uncertainty about the health outcomes that those expenditures are driving.
So that's, I'm sorry, is that, John, is that your final part on this one?
No, let me just get to the final part. Yeah. So the thing is,
okay,
because I think this one is kind of interesting, and I just want to also be fair to WebMD here, that this, the metrics that we're seeing are not surprising because of how how the tool is being used. So what you typically would see in a wellness program are, I think, and this is typically what you'd see, how these WebMD and other vendors are used, is you'd have some kind of an incentive to encourage participation, particularly in a health assessment. Then you'd have a health assessment that would be used to measure the risk of the population and, triage people to relevant programs, and, and including lifestyle coaching. So I think, in fairness, there are a lot of pieces that are kind of missing in how WebMD is being used. Essentially, the content is there, but a lot of the things that you typically see in a wellness program are not there. Which I think has obviously been a challenge for them, to gain engagement. The other thing too with the health assessment is, if you think about, measuring the same group of people over time, that also provides you a way of measuring changes in risk in that population and the impact of the wellness program itself. So again, that doesn't change, the facts that we've just gone through. Is just, I think, important context of how to think through what a wellness program might look like.
And my concern has been that this is where, with OEB being not with the direct relationship with the employees,
Mm-hmm.
It's been hard for us to make an impact here. We're not driving the wellness process. We're not making sure that there's wellness champions everywhere and the like. So it's been that has complicated our efforts in regards to coming up with comprehensive wellness programs for the type of things that you're describing. I have Glenn raising his hand.
Yeah, and I think you hit on it pretty well, Tom. One thing I would point out, the use of incentives is really difficult. We can only do that because of tax issues, on a very infrequent basis, maybe once a year type thing. And it has to be you can't be cash, can't be gift cards. So we're very limited in the use of incentives, which is why we shy away from it. Also, the issue of communications. Yes, we don't have direct access to the members. The only way we would be through emails, and our communications policy is that we don't want the vendors, because there's of course lots of them, having direct email access to the members, because due to some of our surveys, they don't want to receive multiple emails. So we do it on a very really kind of coordinated basis. Our communications team will send out, say, like quarterly newsletters or others that are promoting the programs. And then we have worked with WebMD, who has worked very well with doing webinars. We promote webinars so that people get information. So, and then as you said, we are trying to build up the Wellness Champion Network, and we have regular meetings with that. But again, because we're not the employer, we don't have, kind of control over that.
Yeah. So I agree with takeaways. Do you have a recommendation? Or is that for us? And Jeff, welcome.
Good morning.
John, Kirsten, do you have a recommendation? My recommendation is that
I think I'm not sure that there's really value to continuing this. Is the thought.
And that's mine. That was my read also, is that we would drop the recommendation from SEOW is that we would drop WebMD for the next plan year. Comments from SEOW members?
We were very patient on this program, so I'm definitely ready to drop it.
Bill, I agree with that assessment. I could go the other way if properly motivated, but I agree with the current statement.
And Jeff?
See, I'm off mute. Okay. Yeah, I'll go along with that.
Okay. All right. Just in terms of time, our major effort is around the plan program recommendations. And so, John, it sounds like, can you wrap up our conversation for the next 4 things over the next 5-10 minutes?
Yep. I'll do my best, and
I think the first two
it's
are
going to
the
be
biggies.
easier sailing.
Yeah.
Go ahead,
Yeah.
Tom.
No, I'm just saying the first two are the ones where we really needed the conversation. Yeah.
Exactly, because I think these next ones we can kind of zoom through a little bit. Again, wellness advisors, this is a good program offered by OEB. The advisors are working with the wellness champions, and there's also grants that go along with this as well. So I think generally, and again, I think let's acknowledge this. This is not trying to impact members, but really, this is acting on the entities. So moving on to page, yeah, there we go. Here you can see the grants. There's been a good uptick in terms of so the thing is, 28% of the entities have been engaged by the wellness advisors. You also see a nice uptick in the interventions, which is over 60% increase between 21 and 22 in the interventions. Again, there's been relatively few grants. That's probably the other comment. And I think given and jumping to the thoughts, because these programs are not acting on individual members, the really acting on the entities. And then, moving on to our key takeaways, I think that there's, that these are, delivering value, in the context of the constraints that Tom eloquently just described in terms of not being able to impact members directly. This provides some means of doing it, and it's sponsored by, the program cost is sponsored by MODA. So yeah, I mean, I think I think there's really kind of a continue on type thing is probably the thought here.
Yeah. Okay.
And maybe just
any
it might be
questions
just
from any
go ahead,
questions
sorry.
from the committee members? Okay. Go ahead. I'm sorry, John.
No problem. I think I was just going to package the Kaiser program. Let's talk about those two together. Then let's talk about the two diabetes programs together. So let's, the Kaiser program is around the wellness space grants. And I think everybody understands there's a lot more stress in the school systems and the community colleges, and this is a program to kind of create spaces or havens, if you prefer, in those areas. So let me just get caught up with my notes here. Sorry, one second. Okay, so I think that what you're seeing, and if we move along, so again, there's been a good uptick in terms of the grants awarded over time. So typically the average grant is around $5,000, and that's also the maximum, coincidentally. And then you've seen some greater flexibility as the program has progressed in terms of how those grants are awarded. Next. And again, these are impacting on the entities, not on the members. So, member outcomes are not really being measured. Next. Paid for by the OEB Innovation Fund. And then you can kind of see, what the grant monies, for cycles 3 through 5 is about 375,000. Admin is 135. Next. So again, I think similar to the MODA program, there's value here, especially in the challenges, the context of OEB's challenges in terms of not acting directly on members. The additional comment we have on this one that's a little bit concerning is the relatively high administrative cost compared to total grant fees. So I think that's just something that we would highlight for this group.
Okay.
And then taking the two diabetes prevention programs together a little bit. So these are both fairly new, pretty exciting in terms of their structure and also, the uptake, especially around the Kaiser program. So essentially how this works, starting with the MODA pre-D program, pre-diabetes program, is that, the members complete a survey based on their, based on how they complete the survey, their eligibility is determined. If they are eligible, they receive a 1 hour onboarding call and a Fitbit bundle, which includes a device, a scale, and also a subscription to Fitbit Premium, which are those exercise classes. And then also, this goes back to the community theme that the participants are assigned to cohorts of 19 members, and that cohort meets weekly, with a coach for the first 6 months, and then monthly for the next 6 months. And that uses a CDC approved curriculum. And also, I think the other thing, and then they also meet with a quarterly one-to-one with a health coach. In addition, in-network visits to nutrition are covered as part of this, and there's also online resources that they have access to. So, pretty comprehensive program. Moving on to the next slide, engagement summary. So far, this again just was implemented in October 2022. 41 members had been enrolled. This is it's about a 16% yield rate in terms of people who completed the survey. And this is going to be a comment for both programs that I think, and particularly maybe this applies probably a little bit more to MODA, but it's really doing a better job of targeting members for completing the survey. So I think, currently it's more of a broad approach. And I think that what would be nice to see is using some of the claim data to probably narrow down and have a special communication and outreach program to members that are more likely to need this program. And in terms of member outcomes, still too early to tell. For reference, we have the performance standards here around completions and outcomes. Again, we think this is a great approach in terms of having these standards, and the expectations are set up front. Keep moving along. In terms of the program cost. Oh, go ahead.
Jeff had a question.
Oh, sorry.
Yeah, so on a specialty outreach program, how does that square with HIPAA?
Well, I think that I think that you can do that. I mean, I think we'd have to. That's a great question, Jeff, and we'd have to dig a little deeper. I've seen it done before, but again, we can check in on that.
Yeah, I'm not opposed to it. I just want to make sure we don't get into trouble.
No, I think it's always a good warning, especially, and it also is a member relations type issue as well, too, because people can be a little surprised when they're saying, how did you know this about me kind of thing? How did you know I was pre-diabetic?
Yeah.
So that's actually a very good thing to highlight.
Thank you.
The program, go ahead. Any other questions?
Yeah, you need to wrap it up in the next about 3 or 4 minutes.
Okay, that's fine, because I think we're pretty much done with the cost is, for a completed person is $1,256. You can see the breakdown here, and key takeaways that too early to draw any conclusions, but and I think things could be done to increase the uptake of this program. The cost appears reasonable given the potential cost of diabetes should that occur. And there's a need to obviously assess the outcomes going forward. Okay, moving on to Kaiser, the Kaiser Amada program, kind of a known quantity. Amada has been around for a number of years. A little bit of a similar approach. They have a behavior change platform and they have health coaching that is available for members. The uptake has been pretty amazing on this program. So the thing is, the goal for so essentially they reached 83% of the budgeted goal during the first campaign. As a result, there's been a request for some additional monies to expand the 440, and that's that a request was made and has been granted. So no problem about getting people enrolled in this program. Member outcomes, again, still too early to tell. We have the performance standards here, for your reference. I think this is a good model, for these types of programs going forward. We talked about the uptake. The cost is $455 per participant, and again, there's been an additional $100,000 allocated to this program given the early positive reception. So I think overall our comments would be that both these programs, the MODA Pre-D and the Amada, the Kaiser Amada program, are a good model for approaching wellness programs going forward. They target high cost conditions like diabetes. It'd be nice to see that, maybe the thought would be to do something for the other 5 key chronic conditions, the asthma and things like that. There are interventions on the personal level. They use also a community-based approach. They have per participant pricing. They have robust performance guarantees around things like enrollment and completion and outcomes. So that's it. So again, with these 2 programs, it's really, continue on and see, let's measure those results.
Thank you very much, John. Anything you want to add, Kirsten?
No, I think this sounds like a great wellness plan for the next year.
Okay, so I'm going to summarize what I ended up getting. What we're on for WW for another year, recommending WW for another year, but using this time to look at alternatives and alternatives, or whether or not just there's anything in the space that makes the difference. Number 2, recommend dropping WebMD, continuing MODA's wellness advisors and their interaction with the entities, and with Kaiser Permanente's wellness space grants, and encourage both of the 2 medical plans to keep working on their pre-diabetes program, with trying to get as much engagement as we can get. Is that a fair conclusion?
Those match my notes too.
Yes.
Okay, great. Okay. If no other comment, we'll move on. Thank you, John. We move on to our program recommendations, and that is the for medical, dental, and vision. And so, Kirsten, you're going to take us through this?
Yep, that's right, Tom.
Thank you.
Yep, you bet. Great, thanks, Maggie. Let's just keep going here, and then we always have so many slides at the beginning introducing ourselves. Let's keep going. Okay, great. So we just wanted to set the stage about the timing of everything. So we're really trying to reflect the goals and priorities that were set with the board throughout the December and January retreats in this renewal. And as you're noting, Tom, this is kind of an emerging conversation, because a lot of these programs have a longer runway than just 1 month of talking about things. So we have a variety of recommendations, maybe for work to get started now for next year, and a Weight Watchers solution would be an example of that. And we have some others too. And then also recommendations that could go into effect for the 10/1/23 plan year. And then next year, our idea is to start these sorts of conversations around goals and priorities earlier, so we have the runway we want ahead of time to be having more detailed conversations going into the SEOW process for the renewal. Maggie, next slide. So we just wanted to put into context. So the carriers brought forward their recommendations last month, largely centered on digital solutions that impact members, both in some acute ways. Kaiser had some acute ways and also some chronic care ways. And MODA had their chronic care way also with the VERTA program. And digital treatment options and chronic conditions fit right in with the board's goals and updated goals. We've folded the carrier recommendations into a broader strategy for you, which we've built on, what are the top conditions impacting OEBS members? What are the areas of top spend? What are some innovative emerging approaches for dealing with these conditions that are in alignment with OEBS cultures and what the teachers need and OEBS goals? And then, of course, we're bringing all of these recommendations to you for your approval first, and then ultimately we'd move on to the board with them. All right, next slide, Maggie. And I just wanted to reiterate too, while achieving the triple aim wasn't an explicit goal of the board, it is an implied goal, and it's always there, and we're keeping it in mind as we went through and set this strategy for you. And just to touch on again, we had 4 big well, 5 big goals, 4 excluding legislative influence. We had 5 big goals coming out of December. They focused on shifting left on chronic conditions, communication, this comes up over and over again, came up again in the wellness conversation, reaching members through the school districts and how to impact engagement that way. We have our budgetary constraint of 3.4%. We have our focus on quality and efficiency, and then some relationships building we want to do down the road. In thinking through the shift left idea over the last month, I did just want to mention, when we think about shifting left and the way we've talked about it, in the retreat, we talked about catching chronic conditions earlier, and certainly that's a piece of it. I think it's also catching members who are already down the chronic conditions pathway. Maybe someone is morbidly obese and they're struggling with multiple comorbidities. What does it look like to shift left for them? And so I maybe have a little bit of a different take on shift left now, which is it still includes preventing chronic conditions, catching it earlier, but it also says, let's meet members where they're at and how can we continue to try to shift left for them and keep things from getting worse. Maggie, next slide. So throughout the conversation today, when we get your thoughts, we focused on a couple key areas. You'll hear a lot about shifting left because OEB is spending money on people who are getting medical care, acute care, but also chronic conditions care. Communication is an idea that ties all of this together really and helps us be successful. You're going to hear some ideas for how this all fits in with our 3.4% budget constraint, and that'll have to be an aspect of all of the different conversations we have today. And then within quality and efficiency, we're always looking to steer people to higher quality services and sites of care and providers. And we're also trying to reach historically underserved populations and help get them the additional care that they need. So the next couple slides summarize the carrier ideas that you heard from last month, along with Mercer's thought for whether or not the initiatives would move forward. So Tom, what I was thinking, and let me know if we're on track here, is that the SEOW committee would let me know these ideas that you heard last month, if you what your thoughts were on recommending them forward to the board, and we would make a note, and then we would segue from this carrier roll up into Mercer's new ideas.
From my view, that's fine. Where you have on the slide that you're showing now, where it shows decision, recommendation, those made sense to me. I like that approach. So,
Okay, great.
And I would like, as we go through, I would like SEOW members to where if they run into a situation.
Oh, somebody needs to mute, please.
What are you doing?
There's someone talking. What we need, I need SEOW members to, if you see a recommendation that you disagree with, I need you to jump forward and we could discuss it. But otherwise, we'll move forward because there's a lot of stuff that you have outlined here.
Yeah, and these were, there are two pages of Kaiser recommendations. They largely focused on, we're adding some digital treatment therapies. We are redoing our appointing for behavioral health to make it easier. So, and we thought that these were all good recommendations as well. So we'll just give the SEOW members a
Do you have any estimate of how of what this does to costs, or is that all just embedded in their rate? Because in the past, what we've done is we've looked at each of these, and if it was something that sounded good but was very expensive, we'd say can't afford it, even though it's a good idea. And I don't know whether or not there's a price tag with each of these 10 or 12 Kaiser initiatives.
Tom, my understanding is that these are Kaiser national initiatives that are part of their
embedded
treatment model evolving for next year and are baked into the premium. Yeah.
Great. Yeah, that's and Sapari just confirmed that. That's great. Okay.
Yeah.
So
So
can I ask a follow-up question on that? You know, Kaiser's looking at a significant increase in rates. How much do these 12 or 13 factor into that? That's what I'm not seeing.
Yeah, Robert, we'll take that back to Sapari. Their rating model is a little bit different in terms of how they build their national overall budget model and then allocate down to the groups. For these national initiatives and treatment options, I'll go back to her and follow up with you guys.
good question, Robert. Okay, onward. So I'm not hearing anybody make any other than just the issue around how this Kaiser's these proposals impact their overall rate structure. Other than that, it sounds like we are in favor of what they're putting forward. Okay, let's go on to Moda.
Okay, great. So Moda's options are presented as add-on services to the base renewal. So I'm just going to go through each one of these briefly because our recommendations are a little bit nuanced. Virta, we definitely think Virta is a good option to add to the portfolio of diabetes treatments available. We're going to talk about diabetes and obesity a lot more within the Mercer part of the presentation, but we see diabetic members as representing the diverse spectrum of members within OEB, and Livongo isn't going to appeal to everybody. Virta is going to appeal to some people that Livongo doesn't appeal to, and then some of the ideas that we're going to talk about will appeal to yet a different cohort of people. Virta has a small cost in year one. You know, these programs impact members to a point that, you know, we all talked about earlier. These programs impact members positively for the long term. In the first year, we have to get members engaged and seeing a physician and beginning to impact their care. So in year one, there's a very small cost to this, about 20 cents PEPM, and then beginning in year two, as we phase members off their type 2 diabetes medications, and remember the goal of Virta is to reverse type 2 diabetes and get members off prescriptions, we have real savings beginning in year two onward from that reduced medication utilization. So it's just that year one we have to get through with the small cost. Expanded access to interpretation services, we think is a really important aspect. It came up earlier in SEOW this year. We did it for dental earlier. This is expanding the interpretation for medical. Increased dental preventive visits to be covered at 100% for children. This is a philosophical yes for us. However, to a point that I mentioned earlier, if we think about this is a tough renewal for us and we have to be really strategic about where we spend money, we were thinking that this would be an idea we might table for next year and consider a couple other higher impact ideas for this year. So that was the only reason we said no, was just the financial thought of it. It wasn't a conceptual concern at all. Moda brought forward two really innovative ideas that fall within the social determinants of health realm, medically tailored meal programs and flex funds, and we're working with them to understand and make sure that there aren't any tax implications for members receiving that benefit. So we need to defer that for just a little bit longer while we get the tax impact positively sorted out.
Kirsten, I just have a logical question going back up to the dental preventive visits. There's an X saying that the program would actually reduce costs under the 3.4. So how does that square?
Yeah, I apologize for that. I put the X. I should not have put an X there. So that was my issue. Yeah, again, you know, long term, we hope that the dental preventive visits have a positive impact on members for sure. So what is the SEOW committee? What are your thoughts about this list of initiatives?
Just a quick question. When you say reduce costs, you're for 3.4%, you're just talking about this cycle, not
Yeah,
long-term reduced costs?
yeah, thank you. We need to be careful about both. And maybe it would have even made more sense to have year one and then year two on, because a lot of the shift left ideas really impact people, have a different impact on costs in year one versus year two plus when they're running.
Yeah. So getting back to what Robert had talked about previously, when the Verta that we've talked about has a increased cost for 3 point
Yeah,
for the first year, but then has savings, projected savings subsequently, that maybe we could maybe get a bucket where those costs would go into the reserve funds, because those are ones that the the hope is to use reserve funds for those one-time costs that help us long-term in terms of cost structure.
yeah, help us through. It's like if we can just get through the door,
Yeah.
then we have a huge opportunity available.
So characterizing that, characterizing that differentiation between year one and subsequent years
Yeah.
is critical, and we can maybe have a total that we can assign to that funding source.
Yeah. Mm-hmm.
From my view, I think that the discussion around the last two, the tax implications, I think are going to sink those programs. It's just, and that's just a hunch. I realize that really we do need both MODA and our consultant Mercer to figure that out. But while they're a good idea, I think we're going to be sunk there, and it is going to be a tough enough year that I agree. I personally agree with what you have outlined here. Any other comment from SEOW members? Okay, no comment means we move forward.
Great. Meg, we can go forward. Tom, I'm wondering, should we try to target a break around 10:30? What do you think?
Yeah, that'd be great.
Okay, that's great. And I know VSP brought forth a recommendation. We actually have a slide at the very end. It's sort of kind of a simple enough idea. Maybe we could talk about it here. Our recommendation just on this one was to not make the benefit at a $10 copay for the entire population. Right now, it's already at the lower copay for members where it's clinically indicated that they would have this additional exam, which again, so people are, when you go in for a vision exam, you're getting a manual exam already. If you have eye condition, taking pictures over time can allow the doctor to track that condition and look for changes that maybe they would miss if they did it visually. Those members already have access to this service at the lower copay. So again, just in the interest of balancing costs and trying to make sure we're being thoughtful about spending on high impact areas, we didn't see a whole lot of value in reducing the copay or the cost of the program just globally.
Yeah, and that was the question that we had last month when we discussed this, had to do specifically with what were who was getting this service at a who was medically indicated for it and what were they paying. So what we're learning is that they already are getting, the people where it's medically indicated are getting the lower cost. So I agree with this entirely. If people want to have a picture of their eyeballs, their retina, and they don't have there's no medical indication for it, I don't have a problem with them paying for it. Any other comment from SEOW members?
Yeah, so I agree with that. I just, this isn't the place for it to have a discussion, but I can tell you from my personal experience, like I said this last time, it was a total replacement of the manual for the most part. I just got a retinal, paid for it, and that was it. So we
Yeah.
might want to discuss later on how that process works, but not for here.
Okay.
Maggie, let's go forward a slide then. Thank you. Okay, so we wanted to bring a lot of ideas forward to you to give you a menu of different things to choose from. I will highlight them. They fall in a couple key areas. So just to set the stage for, what we were thinking, again, we're taking the OEBS goals and goals and priorities, looking at top conditions for OEB. So what's impacting your members the most? What treatment options are already available? We'll see, for example, behavioral health is a big category for OEB, but also OEB has done a tremendous amount of work to add so many innovative programs for members. It's really astounding how many options members have available. So we did not spend a lot of time looking to add new programs to behavioral health because we thought the focus there would be more on, hey, let's continue to drive engagement in the programs we already have. So we're really looking for high impact areas where there's an opportunity to add a treatment option that's going to make a meaningful difference. So we're going to talk about weight loss drug coverage. We already talked about redirecting Weight Watchers spend, so we can cross that one off for now. We're going to look within our pharmaceuticals and see what are some top drugs, and there are some cool developments underway in that we want to talk about. Within behavioral health, there is an opportunity maybe to supplement a network of providers available for one of our underserved populations. For our maternity cohort, we want to talk about starting to look at adding a doula program for next year. For our MSK, our musculoskeletal cohort of members, it's actually OEB's top episode category falls within musculoskeletal conditions. We'll talk about the work that's already underway in IWG and explore the idea of adding PRP, which is platelet-rich plasma therapy. And then Maggie, on the second page, these aren't new programs. These are just, again, reiterating, OEB has so many options available for members. And I know we already know this. We're just kind of visually showing it again, that we have the opportunity to continue to drive engagement in all of these programs. And there are a couple specific ones here we'll highlight. And then for the rest of the presentation, we have the condition category, and we have some data to show you about how many episodes we're seeing and how much in spend. We have some ideas, some slides introducing the ideas and background, and I'll be inviting Sarah Drake. She's our clinical pharmacist who's been working on OEB. She worked on Oregon Medicaid as well, so she's pretty familiar with the state of Oregon. She'll walk through a couple pharmacy strategies, and then provided the timing works out, we'll have Dr. Ian Chuang. He's our clinical advisor on the medical side. He's been working with me on the medical recommendations. If he's available, he'll join us. Otherwise, I'll take those as well. Jeff, is a question?
Yeah, I just want to vehemently affirm your approach here, that we do offer so many options, and we just went through that with the WebMD conversation, is really putting forth a strong effort to increase engagement for what we've already offered, I think is just paramount. So thank you for saying that, and I fully support it.
Bill?
What is SO317 disease management? Can you remind me what that is?
Yeah, of course. It's amazing. We have a slide on it. It's such an opportunity. So but I'll just tell you now, it's no big deal. So OEB has so many members impacted by chronic pain. It's not surprising given how many members are impacted by musculoskeletal conditions. And there is a specialist provider in the Portland and Salem area. There are several providers who specialize in holistic chronic pain management. And these providers understand that treating chronic pain requires a behavioral health approach, looking at any sort of past trauma, in addition to treating the pain. And one person took advantage of this service last year. And so I just, when you line up the number of people who could benefit from the service compared to the one the one person who accessed the service, it screams of an engagement opportunity, I thought.
I'm interested. Right.
Yeah. All right, well, let's dive in. Please interrupt me. I know it's hard virtually sometimes to jump in, so please just talk right over me and I'll stop and you can raise your hand. I'm watching that too. So we coined the term OWABonians this month. I don't know if you guys hate it, but we just felt like we wanted something a little bit more personal than members to talk about all of the people who fall within the OEB's purview and benefit from OEB's work. Largely, these ideas that we're going to talk about really focus on shifting left on chronic conditions. We talk so much about chronic conditions because that's really where it's where the spend is, but more importantly, it's where your members are being impacted in their own personal lives. These are the conditions that they take with them every day to work in the classroom. So we help them feel better, and then we in turn save money on the plan, and it's a win for everybody. All right, Maggie. So we're going to set the stage with a slide that just shows OEB's top conditions. And we don't have solutions for every one of these for a couple reasons. We had to start somewhere for the 10-1-23 plan year. And we looked at some of the top conditions that had the potential to really make so we'll highlight musculoskeletal conditions, maternity, behavioral health, and diabetes. And then we've added one not on this list, which is obesity. The reason why obesity is not on this list, even though maybe as many as 30% of OEB members have some degree of obesity, there were only 2,500 diagnosed episodes in the data set. So from a data perspective, it didn't float to the top. Obesity is largely undiagnosed, though we know it's there. All right, great. So musculoskeletal was OEB's top condition category. It includes joint disorders, lower back disorders, osteoarthritis, and rheumatoid arthritis. And Jeff's been working hard with the rest of the IWG committee, and maybe we can go to the next slide, on a surgical center of excellence. And really, when we think about impacting musculoskeletal conditions and bringing a positive experience to the member and influencing plan costs and steering members to high quality, efficient providers, the surgical COE is really the standard of care. We don't have any recommendations around this for 10-1-23. Just wanted to highlight there's a tremendous amount of work already underway for this effort for the 10-1-24 plan year. Next slide, Maggie. We did want to bring up, though, platelet-rich plasma therapy. I don't know if anybody on the SEOW committee has had PRP, but it's a regenerative medicine procedure, and depending on who you're talking to, it's still experimental and investigational, although it's a standard aspect of treatment for major orthopedic providers, including OHSU, will recommend people get PRP in conjunction or prior to surgery. In a nutshell, and it's extremely cool, I've actually had it twice, but in a nutshell, PRP involves they draw your blood and spin your blood down in a centrifuge. And what happens is they separate out the platelets from the rest of your blood. And the platelets promote healing. They take the platelets and re-inject them back into your body. So it's your own biological material with nothing else added. They inject the PRP back into your body over your soft tissue injured area. And it acts like a liquid Band-Aid over that area to promote healing. And so it can actually speed up healing of certain soft tissue injuries. It's not for everything. If you've severed something or completely torn a tendon, it can't, that the PRP doesn't knit the tendons back together, but for minor sprains and strains and other conditions, there's some indication for osteoarthritis. The PRP is really effective. This, Tom, is probably one of those ideas that we would start now for next plan year as we would dig into the data. I was thinking maybe a way to introduce it initially would be for a limited list of conditions at a limited benefit.
It'd be good to have our carriers to run it through their filters along with Mercer to look at it. So that would be helpful.
Yeah, that's perfect. And Moda is looking at PRP. It's been on their radar as well.
And I'd love to get Kaiser Permanente's.
Yeah.
I'm sure has looked at it from a national standpoint.
Yeah. You just make a note of that, Tom. In my
Yeah.
Okay.
I know that. I mean, this has been in the news from for professional athletes for years and years.
Yeah, it's nice to, if we think about the spectrum of members and the spectrum of acuity for a condition. And we have pain management, we have physical therapy, we have surgery. It seems to me like there's an opportunity for an additional pre-surgical intervention that maybe coincides with physical therapy or gives physical therapy a boost. So we will follow up with Moda and Kaiser. Maggie, what's on the next slide? And then we can skip this one. Great, so this was back to the S0317. So this is the data I was talking about. So there were roughly 29,000 OEB members impacted by chronic pain last year. And one member took advantage of these chronic pain specialists. So as I mentioned, it's holistic trauma-informed chronic pain management. So we've engaged our communications lead. Her name is Erin Ward. And for all of these that could deserve, just the program is in place already today. They just deserve more engagement. As she's working with OEB on communication strategy, we're going to try to fold these things in.
It'd be reasonable over the maybe in early next year to have both Moda and KP talk about their chronic pain management approaches.
Yep, noted, Tom. Yeah, I was astounded by how many members are impacted. It's a big opportunity. All right, Maggie, what's next? Okay, so to summarize, so each one of our conditions will have a summary slide. So promote engagement with a digital treatment options SWORD. So here's another example of a program that's already in place for OEB members. We have digital physical therapy. We made a plan for PRP, so that won't be for 10-1-23. And then we'll promote the engagement with the disease management program. But given everything else in place, the surgical COE work within IWG, we didn't see a big opportunity to add anything else to MSK this year.
So, Bill, did you see that S0317 sounds for a CPT code, which is just a way to for comprehensive programs to be able to charge or establish a claim reimbursement for certain types of chronic pain management? That's what it sounds like.
I got that now. I see that now.
Yeah, I didn't get it either.
Name
but
your company,
yeah,
or name your business.
Yeah. Well, it's not. It's not the name of their business. That's just the CPT code.
Yeah.
That's the billing code for the type of intervention.
Yeah, I could have left that
Yeah,
detail off. I didn't mean to make it overly confusing.
But it's chronic disease management for chronic pain, and obviously a huge issue. It's you can fold in the opioid epidemic into that, and a lot of other things.
Yeah, it's such a good point. Okay, Maggie, let's move on. Within maternity, next slide, is another top condition for OEB. We would like to propose that the SEOW committee begin working on building a doula program for the 10-1-24 plan year. It's too complicated for 10.123. There's some licensing requirements, and we need to work through cost and savings. But there is a lot of emerging evidence that it really helps women, especially in some of our minority populations, have positive outcomes and positive outcomes for their babies. So I can walk through some of the emerging studies, but the pain medication and epidurals are given less often. Extreme measures to deliver the baby happen less often, and the babies were less likely to have low APGAR scores. And then there was a second study that just looked at 500 infants delivered through a doula program, and compared to infants not delivered through the doula program, they were significantly less likely to be preterm and have low birth weight. We're seeing gaining traction for coverage of doula services nationally.
So Kirsten, a very short curiosity question. Do the doulas come in right at the childbirth, or is it at a point before the childbirth?
Yeah, it's at a point before the childbirth to establish the relationship with the patient. And one of the thoughts for why doula coverage is so effective is because before the delivery, the doula has the opportunity to really get to know the mom and understand what her goals are, what does she want to have happen during the delivery, and then during the delivery, when maybe mom is busy doing other things, the doula is really able to be there and advocate on behalf of that mom and say, hey, this is not what she wants, or hey, this was our plan, we really want this, or hey, this seems to be going sideways, I want this extra person available.
This is Tom for a minute. I'm having problems with my internet. I've actually dropped off 2 or 3 times trying to find a good place. So if all of a sudden I'm not responding to questions and things like that, it's because I'm having technical issues. The other, just like for the chronic pain, it would be, as getting the opinions of our medical carriers on this. If they can start exploring this, and it would be something we would approach, maybe even during the summer. Kirsten, there may be enough issues that we're raising here that SEOW may need to do, or at least a subgroup of it, need to do some work over the summer as we kind of tee things up.
Okay, yeah, and MODA, we have been talking to MODA about it, and they have
Okay.
a specialist who can work on this program.
And again, I'd be
I'll talk to
also
Kaiser.
interested in hearing what Kaiser Permanente has to say.
Yeah.
So I
sure.
apologize if all of a sudden I'm no longer available. I'm trying to find the right place in my house to promote my internet coverage.
Yeah, understood, Tom. Good luck. Next slide, Maggie. So to summarize where we are with maternity, Kaiser has a maternity at home program, which the SEOW committee is going to recommend. We're going to look at maybe doing some doula coverage work this summer in partnership with Kaiser and MODA. And then I did just want to highlight, within the state of Oregon, there was a recent Senate Bill 1555, which provides for a free in-home visit for newborns. All right, next condition, Maggie.
Should
Great,
we,
so
it's
go ahead,
10:30
Tom.
now. Should we
Yeah, let's do it.
do a 10-minute break?
Yeah, good timing.
Okay. All right, we'll see you all in a bit. Kirsten, before we get started, I'm trying to remember how we're taking these proposals to the board this afternoon. Go ahead, I'm sorry.
No, it's a great question. We gave it a lot of thought as well. So how these ideas are being introduced to the board, and we're making some updates live in the background. So what we talk about will reflect what was talked about in SEOW. But the intention at the board is just to say, um, hey, these are the ideas that are being worked on at SEOW. We just want to give you guys an overview of what are the major topics as part of this renewal season.
Okay. But we will bring the recommendations from the wellness discussion directly to the board today.
Yeah, exactly. So we can bring the wellness recommendations to the board today. We can also bring the Kaiser and MODA recommendations that we
Right.
looked at the first part of today to the board as well.
All right.
Yeah.
So work with Rose to make sure that those, well,
Yeah.
just bring those forward and because I think in my SEOW conversation, it may actually be all subsumed in that other presentation.
Yeah, we'll make sure to work with Rose to do that.
Okay. All right. Thank you.
Yeah.
Okay. Let's go ahead and restart. It's been 10 minutes. And Bill, are you there? I see Jeff and I see Robert. Yep. Bill's there. Okay. Let's continue on.
Yep, I'm here.
Great. Thank you. All right. You're back on, Kirsten.
All right. All right, so focusing on OEB's next top condition, we have behavioral health, about 20,000 episodes and $27 million of allowed spend in this time period that we're looking at here. And if we go to the next slide, though, OEB's universe of existing behavioral health solutions is really impressive. Both Kaiser and MODA have a really comprehensive offering of digital treatment solutions available. There are some specialized programs for adults as well outside of the digital therapy options. And then there are many programs for adolescents that really focus on acute care and keeping adolescents out of the emergency department. So given this universe of treatment options, again, this really is an engagement opportunity. But we did on the next slide, we did want to share with you one potential opportunity we saw. This would be a supplemental care network, and we've been working with MODA. MODA would add it to their network, and this provider network has their own group of 50 physicians, and they really focus on the LGBTQ plus population, and the physicians who work for them are in the community as well. And members love going to them because they really have that congruency of care, and we know that outcomes are improved when patients feel that their provider is congruent with their culture and background. The services, are are relatively broad. They provide primary care and also mental health care support, but really focus on members who are going to be going through transitioning from one gender to another and helping with hormone support, helping them seek a gender affirming surgery, consult, and then actually have that service. The model can be a case rate per engaged member. It can also be just a low, flat PEPM. But given this population is a priority, and um, we understand that there are higher rates of um, depression and anxiety in this population as well, and that the congruent providers make such a big impact. It seemed worthwhile to talk about whether or not we wanted to supplement our behavioral health portfolio with something like this.
I mean, is this something that is this a 1023 issue, or do you?
Exactly. Yeah. It'd be for 10-1-23.
Okay.
And the conversation here would be, as we're balancing all of the considerations between impacting our members and cost,
Mm-hmm.
where does this benefit fall in that spectrum? So it's just a choice available for 10-1-23.
Mm-hmm. And the conversation with Kaiser Permanente is that what they have existing takes care of this, because I know of the development of special clinical entities to deal with this population within Kaiser Permanente. So the assumption is that a supplemental network is not necessary for KP.
Well, I'll be honest with you, Tom. So Kaiser has been doing their own work in this space. They have a center of excellence dedicated to
Right,
this
right.
population already. So
Yeah,
it may be that their answer would align
Yeah.
with what you
Okay.
said as well. I primarily talked
Yeah.
about this with MODA, but
Got
we'll
it.
confirm there's not an opportunity also with
Yeah.
Kaiser.
Yeah, I was actually involved 23 years ago, so I know a little bit about it, but
Yeah.
it whenever we're doing something, it is best that we look at all of our population, let it be a medical. We should look at both Kaiser Permanente and MODA to make sure that there's similar services, and if not, a good reason for it not, and same with dental and same with vision as we move forward.
Yeah,
That's
definitely
just a
noted.
point. Yeah. Okay.
Yeah.
Great. So yeah, sounds great. Obviously, we need to know what costs and things like that are going to be, but
Yeah, for sure. So we can do a little more work. So Tom, on these ideas that we say, hey, yeah, we're interested enough to keep this on the table for 10-1-23. Let's get down to the actual details.
Yeah.
What I think that means is over the next month, we'll shore up the financials, shore up conversations with Kaiser and MODA, and then bring more of a concise decision-focused summary for the SEOW committee next month. Are we in
Super.
agreement on how that would work? Yeah.
Super.
Okay, great. Are you interested in so we could do something similar with PRP if we want to have that on the table for 10-1-23. I know the doula will take longer because there's licensing concerns. That really would be for 10-1-24, but we could gather the similar information for PRP if we wanted to talk about that for 10-1-23.
Yeah, it's just an area that I know very little about, so I would not be able to provide much in terms of subject matter expertise.
Understood.
And so I'm just not sure if Kaiser Permanente and MODA think that they can work with Mercer and address this issue in that time frame. I'm all, for us to be able to make a decision. The catch is that we're 2 months away from having to make a decision.
Yeah, understood. Maybe we'll leave this one as tentative, and if we can get
Yeah,
things,
see what
in,
happens. Yeah, there's
yeah, we'll
nothing
see what
wrong with
happens.
seeing what we can, where we can get, but
Yeah. Yeah, okay. That's perfect. All right, moving on. Okay, so just to summarize all of the behavioral health stuff going on, the biggest thing is let's just keep hammering on engagement and get people using the myriad of services that are available. Kaiser Permanente, the SEOW committee, endorsed their appointing change to make behavioral health appointing easier, and we already talked about our next step on the LGBTQ plus population supplemental network provider. So we'll more to come on that. Great, next. Sarah, are you on? So Sarah Drake
Yes, I am.
hi, Sarah. Well, everybody, please meet Sarah Drake. She's a colleague of mine. She's a pharmacist, a clinical pharmacist by training, and she's worked on Oregon Medicaid, and she's been working on OAB with me very closely over the last month. And she's actually going to walk through some pharmacy data related to OAB and then talk about some opportunities to maybe leverage some of the cutting edge technologies that are coming down the pipeline.
Yeah,
And
great.
Sarah,
Thank
you can just let Maggie know when you want her to change the slide.
Sounds great. Yeah, thank you for the introduction. Even though a lot of my career has been working on Medicaid, what I've learned over the last couple of years where I've been working with public employer groups and associations, that a lot of the opportunities and challenges related to the pharmacy benefit really are very similar across the groups. So over the next few slides, I'll provide an overview of what we're seeing in the prescription drug data. And then, like Kirsten mentioned, discuss some potential opportunities for savings and management over the next couple of years. And as with the rest of the discussion today, we want this to be interactive. So I definitely encourage you to ask questions as we go along. So Maggie, we can go to the next slide. So the purpose of this slide is really just to level set the importance of pharmacy spend as a component of the OWEB entity's overall health plan expenditures over the last year. So as you can see, out of just under 800 million total, prescription drugs represent about 193 million, or about 24%. Please note that 193 million, that's gross of any rebates that are received from the drug manufacturers. MODA is a pass-through contract, and that means that the OWEB receives the benefit of any rebates that are collected from drug manufacturers. And the total rebates passed through, I think, were about 16 million in the last year. And Kaiser is a fully insured plan, so any rebates that are collected by Kaiser are then used to offset the overall cost of the plan. So if we assume that Kaiser has a similar rebate opportunity as MODA, once the offsetting impact of the rebates is considered, prescription drugs still represent about 22% of overall spend for the OWEB entity. And within, if you look on the right bubble there, within the 193 million in the drug spend, there's two components: the spend that's administered through the PBM, and then the spend that's part of the medical benefit. And the medical benefit spend currently represents about a third of the prescription drug spend. So important thing to know here is if you're looking only at the PBM part of the equation, you're missing the whole story on prescription drug spend. We go to the next slide, Maggie. So these are the top 5 drugs in the MODA data. And this is really, it's top 5 in terms of total spend. And it's really pretty interesting. All 5 out of 5 of the top 5 drugs are what could be classified as immune modulators. Immune modulators, they're drugs that treat diseases that occur when the immune system becomes dysregulated and it creates inflammation in the body. So examples of conditions treated are things like rheumatoid arthritis, ulcerative colitis, Crohn's disease, psoriasis, eczema. And in fact, 7 of the top 10 drugs are immune modulators. And so for most of these products, what you'll see is if you look over at that year-over-year trend, most of the growth is happening through an increase in the number of utilizing patients. And there's also an increase in the allowed amount per patient. And that's, of course, the manufacturers of the drugs, they take price increases every year. There's quite a bit of variation in these top 5 in terms of the per prescription price for the products. And some of that is due to differences in pricing, but also some of it is due to dosing. So for example, Stelara and Skyrizi, those are every 3-month injections, while Humira, the top drug, that's every other week, but it's usually dispensed as a month's supply. So there's kind of a difference in how they're dispensed. The fastest growing product year over year, as you see here, is Dupixent. And that's a newer biologic product. It's used for atopic dermatitis, which is also known as eczema, also for moderate to severe asthma. And what we've seen is that eczema indication has just really taken off in terms of uptake of this drug. So this is one of the fastest growing drugs I've seen kind of nationally. One piece of good news is that because there are multiple of these immune modulator products, the manufacturers do tend to offer rebate contracts that will decrease the overall net price of these products. So remember, all these numbers here are pre-rebate. So if you look at like Humira specifically, that per patient cost increase, those increases generally are offset by rebate increases year over year. And then also for that top drug, Humira, we are finally going to see some market competition this year in the form of biosimilars. And we'll talk a little bit more about the opportunity for savings on the immune modulators in the coming years. We go to the next slide. This one shows the top 10 drugs. And so I wanted to just point out a couple additional things here. You can see Trulicity in the top 10. Trulicity, that's a GLP-1 drug. It's used for the treatment of type 2 diabetes. And we've seen really strong growth in all of the GLP-1 drugs over this year. And we'll talk a little bit more about some potential solutions there. Jardiance is also a treatment for diabetes. That one falls in an SGLT2 category, which means that that's an oral product, whereas that Trulicity is an injectable. Also worth noting on here, you see the Trikafta. That's for cystic fibrosis. It costs about $300,000 per year per patient. Manufacturer is Vertex, and they kind of have a monopoly on the CF market. You'll probably see some additional increase over the next couple of years because it looks like there's some partial year users there. So if we go to the next slide. So these are the next 20. So here I just wanted to note Ozempic there is number 11. That's another GLP-1 drug for type 2 diabetes. And Dr. Chuang will be providing some more background and some potential solutions around those GLP-1 products during his section of the presentation. I also wanted to note here Eliquis. That is an oral anticoagulant, and it requires less monitoring than warfarin. And so, you know, that one actually represents a pretty significant increase in convenience for patients, particularly in rural areas, because they don't need to go in and get tested every week for their anticoagulation. And then the final call out I had on here was just Biktarvy. That's a single tablet regimen for the treatment of HIV. It's a once a day dose. It's got minimal side effects, and it really is very effective for suppression of viral load. So not surprising to see that one rise up into the top 20. Before we go into some of the potential strategies, I wanted to stop here and just see if there were any questions around some of the top drugs. Okay. All right, well, let's go to the next slide and talk a little bit about biosimilars. So I'm not sure if this group is familiar with biosimilars. It's a type of a biologic drug. And sometimes you'll hear biosimilars to biologics are like generics to traditional drugs. It's a good analogy to think about it. It's slightly different. So biologic drugs are really complex molecules. They're difficult to replicate. The best way I've ever heard it described has to do with the manufacturing process. So like with small molecule drugs, they're made in a lab based on a recipe, precise combination of the raw ingredients. They put them together and you get the exact same result. Whereas the biologics are created in a manufacturing process that it uses living cells to replicate complex proteins. And so the cells get programmed to create copies. And so you can produce multiple copies of the protein using that process in a different environment, but there might be subtle differences in how like the protein is folded, for example. And so the FDA does regulate biosimilars through a different pathway than generics, but they really are expected to have not any clinically meaningful differences between the biosimilar and the innovator, and just in terms of safety, potency, purity, and effectiveness. We go to the next slide, we can talk a little bit about the biosimilar timeline. And so this timeline really shows the evolution of the biosimilars from the very first product we saw in 2013 to today. You'll note 2016 really ushered in, some of the beginning of some of the top drugs that we've seen in the OWEB population. And you'll also see that the number of biosimilar approvals has really increased significantly over the last couple of years. And I want you to look at what's on the horizon for 2023. So Humira, that's the top specialty drug. We're finally going to have biosimilars for Humira. The first one was actually FDA came to the market last week. And then we're also expecting biosimilars for Stelara, that's your number 2 drug, by the end of the year. And so there could be a first biosimilar and then some follow-ons coming in 24 and 25. So let's talk a little more specifically about Humira if we go to the next slide. So beginning just last week and then continuing through 24, we're expecting up to 14 additional biosimilar products for Humira. And that's going to include both the original formulation as well as there's a newer higher concentration formulation that the manufacturer of Humira has made available. When the first product launched last week, it was pretty interesting. It actually launched with two different NDCs. NDC is like the package of the drug, and they have different price points. There's one that's a 5% discount off of the brand Humira, and the other one is a 55% discount of the brand Humira. And Amgen is really doing that bifurcated strategy. So then they'll be well positioned both for plans that are looking for higher rebate and then plans that are also looking for lower list price. So they have something for every plan, I guess. So we are expecting 7 of those biosimilars in 2023, and then the other 7 into 2024. There's considerations around, what's it like for the members? What's the member experience? What is the interchangeability of these products? So some biosimilars are interchangeable. Some are considered similar, but not interchangeable. And all of those things really can fit into some of the decision of whether or not a member could be easily transitioned to a biosimilar. But I think the thing to note here is that the biosimilar situation for Humira is really rapidly evolving, and it should definitely be considered a potential savings opportunity as you're looking forward to 2023 and 2024. So if we go to the next slide. And so one of the things that we're hoping to think about here is a biosimilar strategy. So with some of these top drugs having new substitutes available, what are some of the pros and cons of maybe preferring a biosimilar rather than preferring that brand name drug? And so this slide really provides an overview of some of the opportunities and some of the challenges. And the opportunity, of course, as these biosimilars come out at a lower cost, we know that at least one biosimilar is coming out at 55% less list price than the brand name. That can, have a lower cost for the plan, although you do have to look at the difference in net cost, which would factor in rebates. There's a hope that both plans and members could win under a biosimilar strategy, right? With a lower list price, that could mean a lower member co-insurance as well. And then another thing to just kind of have on the radar is the Inflation Reduction Act that passed last year is just expected to really create some additional incentives for adoption of biosimilars, particularly in Medicare. And so just as there's those incentives to move members over to the biosimilars, the providers are going to be more comfortable with them, and we might see biosimilars being used earlier in therapy. Now, there's not without challenges, right? So there's going to be an uphill battle on market share. So the manufacturers of the brand name drug have really built their market, and they're going to try to keep as much share as they can. We've seen with Humira that the brand manufacturers can update their formulations to make it more difficult for those other manufacturers to make kind of essential copies of their drug, so they can have a preservative-free version, or they can have a higher potency version. With Humira, I think we're going to see interchangeables even for the new formulations, but it is just something to be aware of. Brian, I heard a question.
This is Tom. What you had raised earlier really is important in regards to the impact to the member. So the cost, rebates oftentimes aren't seen by the member. At least that's my understanding. And so we're going to have to pay very close attention. Lower list price in general is going to be best, at least my understanding of it is best for our membership. So we need to be guided in, if there's a principle there, it's what activity results in the best outcome, financial outcome for our membership. That's just, I think, a principle that's a principle. And I don't understand the complexities of pharmacy rebates and things like that. So this is just a 30,000 foot level comment as compared to, okay, what do you do with drug X, Y, and Z?
Absolutely. That's a really good point. And I think one of the extra challenges in this case is that the manufacturers of the brand name drugs tend to offer coupons or copay cards to members, so that, that can be a challenge to the biosimilar adoption, because from the member's perspective, if they have a copay card that's making the drug free, they might not see the financial advantage of a switch to a biosimilar. So all of those pieces really need to be considered to make sure that the member is getting a drug that's not only safe and effective, but also is the best financial decision for the member. I think we can go to the next slide. So this one is just an illustrative cost breakdown of how Humira and a biosimilar might compete in the market. And so in this slide, the total height of the bars represents the list price for the drug. So we know that the first biosimilar for Humira actually launched at 2 different list prices. And so there would actually be 2 different biosimilar bars here, one that's shorter, but would not have that dark blue rebate component in the middle. We expect that both Humira and the biosimilar are going to provide a discount off of their AWP price. And we also expect that member cost share, that purple piece in the middle, could be covered through a copay or a coupon card. And so both the brand name manufacturer and the biosimilar manufacturer, Amgen, or the other manufacturers that come in, are likely to offer copay or coupon cards to the members. We do think that Humira is going to have to offer up more in rebate in order to be competitive, given the additional biosimilars on the market. And so even if you're not seeing that decrease on the front end, you should see some benefit of increased rebates as Humira needs to compete. So again, here, I think the big thing is we think that some savings is possible on some of these top drugs with biosimilars. But there's also a lot of different factors that could affect the amount of the savings. And that's especially around the rebate contracts and then some of the other market dynamics here. We go to the next slide. And there might also be an opportunity here for a product selection strategy. So this is just an example. So you saw the top 5 drugs were all these immune modulators. Here's the top 2, both Humira and Stelara. And what you can see here is that some of these the drugs have some indications that they're both marketed for. So, Crohn's disease, the member could use Humira or they could use Stelara. And so it might be worth looking to identify opportunities for members to select Humira rather than Stelara, knowing that the price is less and knowing that there's multiple Humira biosimilars that are imminent. And I do want to acknowledge here that existing users might be reluctant to switch to Humira, given that it's administered more frequently. It requires more shots.
Keep a bug in my ear. Sorry.
Yeah, that's okay.
And like my whole work world happening at the same time. Right?
There might also be opportunity for new users to make sure that they're stepping through from Humira first before they're going to the higher cost Stelara. So if we go to the next slide. So just some options to consider. The brand Humira could be moved to non-preferred, and you could have a biosimilars first strategy. Alternatively, it could be made co-preferred along with the biosimilar. And really, those rebate contracts are going to be a major deciding factor here. Also, we'll want to consider member disruption, provider disruption, especially in the context of some of those biosimilars that might not be considered interchangeable. And then again, you definitely want to consider the experience of members that are taking Stelara, and there might be an opportunity for new users that need one of these drugs for inflammatory conditions. Perhaps they can try the drug that has a lot of competition and a lot of opportunity for lower price first. I see Tom's got his hand up.
Yeah, so I understand Mercer as the consultant coming forward with this as an idea recommendation. Where is MODA with this? Because aren't they the ones that would have to bring forward the recommendation?
Hi, Tom. I'll jump in here on this one. So the way I thought about this particular strategy, because especially with Humira and the biosimilars, the timing is going to be a little bit awkward on this one. We'll have to vote on things before the negotiations actually take place and we see how the market transpires and things really heat up in the summer of 2023. So I saw this more as a, oh, and I see Katie has her hand up too. So Katie, we'll get to you. As you know, SEOW can think through what would be their ideal scenario for members, and then what would be a backup plan, and what do we want for next month? Do we want to explore? Because right now the HSA plans don't differentiate between preferred and non-preferred in terms of the cost share. So what do we want to work on with the carriers over the next month in terms of the biosimilar strategy, knowing that we need to have something, some sense of direction from the committee and the board going into 10/1/23, because this is all going to really heat up this summer. So if we wait until next renewal, we'll be behind the ball.
Yeah. So you're thinking that, I mean, what we want, I mean, a proposal would be, we want high quality products that are the lowest cost to our members, and authorize or ask MODA to move in that direction.
I think so. You also
and
raised a point earlier about list price versus a higher cost drug net of rebates, and the financials of that are a little bit different, even though rebates are
yeah,
when rebates are passed through to OEB. So you might have a higher list price offset by a rebate. The rebate comes into the renewal calc and it's shared by all the OEB members. So they
yeah,
benefit equally from that, whereas a lower list price benefits the member who's taking the
the
drug.
drug. Yeah.
Right.
So
So
for
it's a
my,
little bit of a difference
yeah,
there.
that would be a, Robert, I think that's a conversation that the board should be very clear about in terms of what, from a system standpoint, what we would propose. That we ask MODA, and again, I don't know what we need to ask Kaiser Permanente how that influences, but from a policy standpoint, we should look at, we should either be, it sounds like the two options, Kirsten, are one where you maximize minimize the cost to the individual taking the drug, who are usually just being pounded by this stuff, or you minimize the cost to the plan, which means being divided out over all of the population. It seems like that's something that the board should have a clear policy in terms of directing its medical plans.
Yeah, that does seem like a board policy decision. Also, I think exploring the HSA plan, and is it time to have a
Yeah,
preferred versus non-preferred tier? In a way, drug price is a natural influencer, but that's not the only factor in whether a drug is preferred or not preferred.
right.
Yeah.
I agree. So it's
Katie,
complex stuff.
yeah, it is. Yeah, the biosimilars are very complex because there are so many market factors, many of which are
Yeah,
yet to play out. Katie, did
yeah.
you want to jump in?
Pardon me.
I think you might be on mute. We can't quite hear you, Katie.
Oh, And then Sarah, did you see my note? We need to wrap up the pharmacy by
Yes.
11:15. Perfect. Thank you.
Hi, can you hear me now?
Yes, we can.
Yes.
So sorry about that. I just wanted to jump in and say really quick, Tom, that's exactly what we already do today. We work every day managing the formulary as such, and we've already had experience with biosimilars, and this is something that's automatically done by MODA to manage the formulary. So we do look at overall net costs. Biosimilars are a great opportunity. These are managed through prior authorization, and with our specialty co-payments under the pharmacy benefit, there is a cap on the different tiers. And so when we choose a preferred product that makes sense from an efficacy, safety, but cost standpoint, then it's on a preferential tier to the member, It's managed through prior authorization, supported by our specialty pharmacy. So we're already well in advance getting prepared for the Humira, talking with industry, doing analyses, understanding this. So I'm not sure that this really requires board action. I'll leave that to you, because this is something that we do today already for OEB.
Yeah, my question though would be, in that situation, do you, I'm not sure that you minimize the cost for the individual versus minimize the cost for the plan. And
Yeah,
if that's already clear, if that's clear and
yep.
we have a policy on it, that's fine. But if we don't, then we need it. That's all.
Oh, great. Yes, we do. So
okay,
good to hear we're aligned. Thank you.
Thanks, Katie. If we go to the next slide. So just in summary here before we turn it over to Dr. Chuang. So I think there was a discussion earlier about decreasing the insulin max to $35 that came from Kaiser Permanente. And then also just in terms of focusing on high quality, efficient care, just being ready to capitalize on the biosimilar savings, and both from the plan perspective and to the point made on the member perspective as well. And then also just looking at product selection strategy too. And Katie did note that they currently do require a trial and fail of Humira before a member can progress on to Stelara. So that's good to see, and we can definitely talk with them about some of these other immune modulator drugs too, to see if there might be opportunity there. I think with that, I can turn it over to Dr. Chuang unless there's any other additional questions.
Thank you very much.
Okay, let's go ahead and jump into this next section here. And thank you for the privilege of your time. It's a pleasure for me to be here and leading this next section and discussion. I'll leave my bio in the interest of time and just kind of dive in. Next slide, please. Just to go over a few highlights as I was, so, I'm a family physician, and my approach to this kind of work and consulting is really to be clinically based, data driven. So as I look at the data and understand OEB population a little bit better, there's some things that sort of stick out. So just want to highlight a few things. Here's some national statistics in terms of just the prevalence of diabetes. Significant numbers, obviously. But when we're looking at the data through OEB, it's through the lens of available utilization data. So when we're seeing that we know of at least 5,000 plus OEB individuals with diabetes, it's based on the fact that they are actually receiving care in this context of somebody coded a diabetes code that we can identify and see that. So it is for sure undercounting the prevalence. And then we have the even more difficult group that precedes diabetes, what we call the pre-diabetes population, which is an additional significant number that physicians typically don't code. And they are sort of a part of this principle of how do we shift left and tackle the precursors to this population that's of risk. Next slide. So that being said, if we extrapolate and look at sort of what's going on with those known populations, this is just a summarization to illustrate, with the diabetic populations that we do know of currently, the direct cost of care, specifically around diabetes, amounts to about 24 plus million. But then there's all these other comorbidities in which either having diabetes leads to and complicates, creates those comorbidities, or they aggravate the underlying condition. That sums up together to be about double the amount of 50.8 million. In the aggregate, it's a lot of cost that is either directly or indirectly attributable to the presence of diabetes. Next slide. And then when we extrapolate, so if those are the known individuals with diabetes, then if we use sort of census data and epidemiological data and expand that out, what would that potentially look like over time, right? So diabetes doesn't go away on its own. It tends to progress unless we optimize the care and reduce the physiological disease progression. This is sort of that sum cost, right? potentially amounts to 9.4% of the population that will be contributing an additional sort of $74.8 million of cost to the plan in various forms. So this was just a breakout of, the costs attributable to type 1 versus type 2. Obviously, the larger proportion is type 2, and then the associated complications. Just for point of reference of what we're dealing with, immediately obviously, but then what's underneath the surface and what's potentially going to roll out over time. Because with a population that is staying employed and tenure over a long period of time, the underlying disease progression will reflect in the plan, if not this year, in the following subsequent years. Next slide. So I think I was made aware of this concept of shifting left, right? I think this is the desire and the opportunity for us caring for this group of individuals and trying to see if we can alter the course. So the natural physiological trajectory is to continue to have worsening diabetes unless we treat effectively, intervene with some lifestyle and behavioral choices that can modulate the underlying condition. And to an extent, some factors are non-addressable, right? Race, ethnicity, genetic factors. But if we look to the left, it's getting that pre-diabetes identified early on and starting to make those changes that can slow down the progression, if not halt it. And then the two of obviously are pre-diabetes and obesity. So that's why part of talking about type 2 diabetes, I think it's important clinically to also think about the overlapping population of obesity. 50% of the newly diagnosed type 2 diabetes are due to obesity, and those with diabetes have an overlap of a significant number of concurrent obesity, and both are interacting in a negative way. So next slide. So if we look at the population of obesity, this is one where it is definitely not coded well within utilization data. So it is grossly undercounted. We treat many things that are aggravated or brought on by obesity, but the treatment for obesity itself is a very smaller number. However, if we looked at U.S. population census, it's almost 42% broadly. But even at that, Oregon as a state tends to be a lower prevalence. It tends to be a healthier state overall in terms of the population within your borders, which is good news. But that being said, there's a potential to have within OAB almost 31,500 individual members with some degree of obesity underlying. And if you extrapolate against, again, the costs that we are seeing with the known obese population to potentially those that are unknown underneath the surface, again, it's a significant cost impact. If we leave it unattended and letting the natural prevalence and disease course continue on. Next slide. So this is that extrapolation of cost, right? It's if we look at the overweight obese population currently and stretch it out to those that are undiagnosed and compound that cost factor, that's what it can net out over time. Okay, so with that background, let's kind of take a look. So again, diabetes overlap with many conditions. In the high cost claim reports with the high top cost by RX, obviously those have very specific diagnoses that are associated with those costs. But the underlying factor of obesity can often be a complication, be a risk factor from everything from cancer. Certain cancers are sort of lipid related or dependent as a risk factor to obviously the cardiac related disorder as a direct correlation to that. But then for things like low back pain, it's just more common to have a musculoskeletal, osteoarthritic, and low back pain showing up in claims because of the higher rate of incidence and prevalence of that. Okay, next slide. So in terms of our option, just like obesity and diabetes is a continuum. I think we need to also think about the individuals with those conditions as not one single patient type, it's a continuum. So should be the interventions, programs, or services that we're contemplating for this population. Very rudimentary, but I think this is a sort of to show you the couple of extreme ends of that option, using the Weight Watcher as a reference point that is current and available. Obviously, it's more of a self-help, self-initiated resource to take advantage of. And then if you go to the extreme where we're trying to do something significant, like a surgery, a procedure, to alter the physical anatomy in a way that, one, produces an immediate impact, sort of jumpstarts that individual on a trajectory towards lower weight. Now, obviously, they still need to do things to help them maintain that weight, because there's always the risk that some of the weight trickles back in if all else is kept equal. And this is the continuum that we need to think through. Now, bariatric surgery is not for everybody. Not everyone should qualify or meet the criteria. But for certain high risk, the speed to improved weight, and when I say improved weight, obviously clinically we all agree, we're not trying to get everybody to be skinny. That's not the goal. It's just a differential and meaningful reduction in the weight that from a physiological metabolic perspective, it's meaningful. It's changing the speed of that disease progression that's underneath. The bariatric surgery, as well as medications, can do that. It basically, when complications can develop as quickly as within 5 years, sometimes the slow, steady approach, you're losing time where that disease process continues underneath the surface. Bariatric and what Sarah mentioned, the GLP-1 medications, for example, gets you that meaningful weight reduction quickly. And then we can work with and support the individuals to maintain that weight. There's both a physical benefit. I think there's also a psychological benefit, right? They all of a sudden feel the benefit of that lower weight, meaningful weight reduction, while they do the hard work of addressing lifestyle changes and choices and things like that. Next slide. So on the medication side, the medications are here. For better, for worse, almost everybody has heard about them, right? So from the clinical research side of things, clinicians know about them, and they're starting to prescribe them. They are incorporated into the ADA practice guidelines and things like that. But then on the consumer side, thanks to social media, thanks to pop culture and everything else, there's definitely awareness of this class of medication for both clinical reasons as well as sort of what I would call sort of cosmetic and superficial reasons. So those are the forces at play around these medications that are very costly. We want to consider them, and I think they have utility. One thing to be clear about is within the same GLP medication class, there's a couple that are specifically indicated for obesity, and that's the Wegovy and Saxenda. They're similar to other medications that have been approved and are used for treatment specifically around type 2 diabetes. And part of that is because this class of medications often have dual benefit. They are improving the hemoglobin A1C, which is a marker that's helpful for knowing if the diabetes, the glycemia is well controlled. But a secondary benefit and impact is around the weight management, weight reduction, right? So we typically think about 10% or more as a meaningful weight reduction, which is hard to achieve. It's a slow slog, just focusing on nutrition and weight and physical activity. Whereas these medications get you there relatively quickly within a 4 to 6 month time window. So again, it's that speed to improved weight and glycemic control, and plus the sustainability of that control, which is the main benefit. That is ultimately the goal. Okay, next slide. So here's the snapshot. So I think you got a preview of where and how some of these medications that are considered GLP-1s and SGLT2s that do control diabetes, and for some GLP-1s also have the benefit of weight, are trickling up the top RX list, right? Typically before, they were all specialty RX, chemo agents and the immunological medications. Non-specialty medications from diabetes are starting to trickle up. They're moderately expensive. They're not crazy expensive, but because of the prevalence, because of the number of patients that are getting prescribed this, and the number of patients potentially that need to be on this, that's the risk. It's the volume times the moderately expensive medications. And you can see the net totals here, just between GLP-1s and SGLT2s as a percentage, right? That's almost 50% of the total diabetes related cost. So that's significant. and that ratio is only going to continue to grow. So we have a choice and an opportunity here. Given that these medications are useful and effective, do we want to think about ways to create structure around them in terms of how they're prescribed, so we ensure appropriateness, but ensure access and getting that benefit quickly, but supplemented with a holistic approach and the other things that need to take place if we're going to improve the diabetes, obesity, high-risk group, and work towards outcomes. And one of the outcomes should be also these medications will work, and if you stay on them, they should continue to work. But it doesn't mean that's the only option, right? So that becomes a very high-cost medication for a lifetime. Unfortunately, as physicians know, medication seems to grow only as we age. It's not a done deal. If we are purposeful, we can get some people off medications that can be improved through lifestyle choices and behavior modification. So it's been focused on outcome, where one of the outcome is not needing the medication if at all possible after a given period of time. Next slide. So here's the short list of the medications, specifically GLPs for diabetes, and their cost over time, year-over-year change, and the average prescription cost. So as we were talking about, the cost and the prioritization of costs at what level, plan level or individual. Here's one that's for a very common chronic condition. So it's going to be a broad portion of your population. And knowing the social, economic, and demographic distribution of diabetes and obesity, there tends to be higher among the lower socioeconomic groups. Something to consider is also potential being underinsured, even though they've got a health plan for whatever reason, financial plus their salary. These costs may be prohibitive once you factor in the premium and out-of-pocket cost. So something to keep in mind as we're thinking holistically on across the whole group. Next slide. So with that said, there are programs that focus on sort of optimizing, given that these medications are going to be prescribed, given that they can be effective for diabetes as well as obesity, and the fact that the overlap of the two is significant risk amongst this group, there's an opportunity to kind of approach this holistically, recognizing there's a genetic and biological undercurrent to this, so we can't sort of diet our way out of this for everybody. So as important as nutrition and lifestyle and physical activity is, it should be a baseline for everybody to further improve and optimize. It may not be, it's necessary, but it may not be sufficient. And we also know there's a mental health component to this, as well as sleep and environmental, right? Some of the social determinants. So if we want to approach this and really be impactful for a broad group, it is going to need to be a set of options for them. And one of them is around the medication. Next slide. So I think this is clear now that there is a correlation between increasing severity of obesity with cost, direct and indirect. So next slide. And just to be respectful of time, we're still doing okay. So then if we look at how do we want to create and surround the individual within a health plan with options that could be tailored, that can be aligned to where that individual is, both physically and mentally, to help them optimize the best chance of achieving a meaningful improvement for themselves. There is a continuum, right? There's a pure lifestyle choice focused solutions like Weight Watcher and Noom, all the way through the more aggressive options that do produce meaningful impact. That includes bariatric surgery and obviously these weight management drugs. But if we think about these two as not the silver bullet, but rather for those high risk individuals, it gives them the benefit that they need while they still probably have to spend some time focusing on those other personal choices and behavior that needs to be addressed. I saw a hand up. I can pause there and take a question.
Yeah, this is Bill. I just wanted to just clarify, I think I know the answer, but is BMI, based on your last slide and then all the previous slides from the last slide, is BMI the sole measurement on the diagnosis of obesity? Because I'm wondering if there's more to it than that, than just BMI, because I only see BMI in your slides.
Yes, so I think we know there's many factors, and obesity, is not as the obesity as measured by BMI is one way of quantifying that. It happens to be, for lack of a better term, the simplest way, but it's not the most precise and comprehensive way. But we are sort of at a challenge in terms of having universal access to data in a way that helps us to identify and risk stratify. So having weight and height in this formula tends to be a common and somewhat easier way, recognizing that there's always the outliers where either due to bone density or muscle bulk, it's distorted. It's not correct. So yes, that's unfortunately one of the indicator. And I would think that at least in the context of speaking about a morbid obesity, that it's high enough that it's not usually typically just because of those other factors that may confound a BMI value.
I do agree at the higher end, it's clear.
Yes.
I'm just saying that there's exception on both ends. But I was just curious if that was the only thing we still have. That's been around for what, 20, 30 years, right? So it's just, have we come up with anything better to diagnose the comorbidity level of obesity with other diseases?
Yeah. I mean, there's caliper measuring and other techniques that get a better sense of the distribution between body fat versus muscle. But that's hard to do. We don't do it consistently or easily. That's the limitation. But that being said, again, just to reiterate what I stated earlier, the goal is we're not trying to achieve a perfect number, and it's not to get everybody skinny. There are plenty of skinny people that do not lead a healthy lifestyle, and they're equally at risk of other types of illness. But that being said, we do know there's a factor of risk that comes with higher weight, and a meaningful drop, that 10%, just changes the body's metabolism and physiology enough that it would reduce the risk on an ongoing basis. And that's what we're seeking. Next slide. So one way to think about this, so again, if bariatric surgery and medications, we don't view it as a silver bullet. It is the balance between optimizing the use of those medications so we get the best value, given that they're expensive enough, plus a deliberate approach around intensive lifestyle intervention to support, guide, and educate the individual for what they can do to mitigate and move forward. And the goal is to achieve a 15% weight loss. And there are programs that sort of focus on that outcome with performance guarantee, not just on participation, right? So it's not just based on the number of people that sign up, but the willingness to say we can manage the individual, coach them, educate them, and guide them sufficiently that over time, relatively quickly, achieve the weight loss, plus with the goal of getting them off the medication, say at a 2-year mark. Otherwise, these medications end up being unmanaged, and the easiest path is just to continuously prescribe them year after year, which isn't productive both from a plan level or member health. Next slide. So we can be thoughtful about this, right, and approach it with clear criteria where those that can benefit from them and they personally are aligned and willing to step up and step into a program like this, work hard at it, let the medication do what they do with the expectation that we work towards a 2-year goal of getting them where they need to be, but no longer dependent on the medication. So this is not thinking about the medication as a silver bullet. There's a way to get to cost-effective outcomes. Next slide. So how that would play out is, like I said, right now your medications are hitting your RX claims, right? Significant numbers, significant cost. As a physician, I know our creature of habit is, hey, it's working. Let's just keep them on this medication. They've done their weight improvement. That's that first line. These medications only increase in terms of number of patients prescribed, and they'll be perpetually being prescribed unless we are purposeful and deliberate in driving towards outcome. And with a structured program, we can do that by saying, hey, there's a goal that we're going to aim for by 18 months, evaluate them with a desire to get them off the medication, yet helping them achieve their optimal and better weight. And that changes the cost curve from the medication. It's still significant. These drugs are not cheap. They're not the equivalent of generics, but they can produce value. And like I said, the value is over time, because we're slowing down the disease progression that for an employment group that has long tenure, if not now, if we don't do anything, they will develop the heart diseases, the kidney renal complications in future years. Next slide. So this is a strategy, we want to shift left. Those that we know of, help them improve. And then those that are on the road towards diabetes because of the underlying obesity factor, start to change that trajectory in a meaningful way. But it is not a one and done sort of approach, and a population that continuously carries that risk. It has to be a multi-year strategy with a mindset of doing the right thing over time to ultimately improve the group as a whole. So it's the savings. If we're thinking about ROI, this is one where I don't agree that anybody doing a 1 year pre and post ROI calculation is credible or meaningful. But it is about tracking this cohort over time, seeing how they improve, and then over time, seeing the improvement in their cost utilization profile as a group. So let me pause there. Any questions on that? We can continue on. Okay.
Dr. Chang, while the SEOW committee is thinking of questions, I'll just let you know we did touch on the VSP already, so we don't have to cover that very last slide. Okay, thank you. So with that, let's no question. Let's continue on then. So so this is potentially an approach. All right. So what we know for sure today is it's not covered, but then something to consider and get guidance and feedback from the SEOW is consideration for making sure we have a balanced approach to coverage, balanced across plans, and then also think through where the risk groups are, making sure that the availability and the access and all that is equal and balanced across all groups, and tackle both because of the significant overlap and coexisting risk factors of obesity with type 2 diabetes. Provide that coverage, but manage it through criteria-based enrollment, right? So part of getting the medication is ensuring that they're approaching this holistically, including intensive lifestyle intervention to supplement and support the use of the medication, with an expectation between providers and the member, patient themselves, the teachers, that they will work towards a goal of getting off the medication after they're hitting a meaningful weight loss over time. And then we can move forward beyond the highest risk group as we get visibility. So much of the value of any program is obviously awareness to start, and then engagement, and then active participation to drive towards outcome. So I think once we focus on the highest risk group, we can consider stretching that out further into the moderate obese population. That shows your next wave of potential risk, and see how that goes. Let me stop there. Yes, Tom?
Yeah, so question that I had was about what happens after 18 months with people having, let's say, lost 10% of body weight. Do we have large studies that show they regress, they stay the same, they continue to lose when they're off medication? I'm just wondering if that's been studied.
So there are broad populations, bigger population studies that look at that, and a couple of things was gleaned from that. One, those that get a meaningful benefit relatively quickly, within 6 months, tend to be able to maintain it over time, because there's always the risk that you got good success early on, but then it kind of trickled up, and that is true for bariatric surgery as well. When all else is left the same, right? So if we come into this as an individual patient potentially viewing the medication or bariatric as a silver bullet, meaning this is the only thing I need, and I'll just go my happy way, then yes, we know recidivism, a certain percentage of that weight comes back. And that's why the importance of the concurrent intensive lifestyle interventions to supplement that, with the expectation that even if I'm on these medications, I as an individual has to do some changes myself to sustain what I feel is now a better weight for me. So it doesn't come automatically, and it has shown that those that can maintain, there's always a percentage that will kind of regress, and I think that's true for any larger group, and that's something to work on, right? So it is not, we shouldn't have that expectation that that's just a normal expected failure rate, but through a comprehensive program, we may find that having the right choices after they finish the medication to have that ongoing support service program is what they need to just be that motivator. So that's tough to figure out because at the end of the day, it's behavior, and behavior is hard.
Yeah, one of the things that that in the Mercer, and Glenn, we'll get your question next, but one of the things that we saw in your recommendation was potentially funding this by using the WW or Weight Watcher money. That would, my quick math shows that that would fund 100 people. And we have obesity rates, you know, as you've identified, of 34,000. So, and if we traded 10,000 people, just the drug cost would be $120 million. So the scope of this is one that we're going to need to think about and see what we can do. As with our other conversation, I mean, I really appreciate you bringing this forward. It's moving my thought processes forward, and but again, we're going to need to see where our two carriers are thinking and whether or not they have are dealing with this and approaching this. So that was my only comment. Glenn, you had a question, I think.
Well, I just had a quick question, and I don't know if it was discussed, is, you know, these being new drugs, and from what I've read, there are risks to these drugs because they are stimulating the pancreas, and that you have potentials like for pancreatitis and other, I guess what I'm saying is, have there been long-term studies of these drugs and their potential side effects?
Sure, thanks for that question. So these are the newer category, but they've been around a number of years. So we do have at least some longitudinal experience and knowledge of it. So there are definitely side effects. So some of the indirect cost savings, given that these medications are already being prescribed, will come in a couple ways. One, you know, unnecessary prescribing, let's say, of a 90-day to start when the patient doesn't have support to help them with the side effects. So GI is a common side effect with this. So the potential is just wasted costs, right? They took that shot or they took the pill and a couple of times and they said, well, I really don't like this side effect, but nobody was helping them to coach them through it or modulate the dosage. So that's a potential a structured program can help with that, the unnecessary wasted costs. The other one is, again, given that these prescriptions are being written, as far as we can see from history, they tend to be perpetually written year after year after year. When there's a program structured specifically, and they're going to accept a performance guarantee, for example, of trying to get the patient off the medication by the second year, end of second year, it's that cutoff of cost that says, okay, yes, we're paying for the medications 2 years, and we'll put a performance guarantee on that, so a percentage of their payment at risk, and then stop the continued use of that medication. That's the additional indirect cost benefit. But that's why it has to be something that we think through and commit to as a strategy, not just a 1 year, but a few years to really get the benefit.
And Jeff, I see
Jeff,
you have your hand up, but Tom, I just wanted to mention to you that that we would not be recommending carte blanche coverage of the weight loss drugs specifically to manage the costs that you mentioned. If we focused most on high impact, it's a small percentage of that.
Right.
Okay,
Right,
just
the
so we're clear.
40 plus. Yeah, I saw that, no
Yeah,
question.
okay.
But it's more than 100 people. Might be
Yeah.
1,000
Yeah,
people.
it's more than 100 people. And the financial, you know, assuming the SEOW committee is interested in going another month with this and getting
Yeah.
finalizing things with Moda and
Yeah.
Kaiser, and you know, we have some initial cost work done, and we can finalize that and bring it back and show everybody
Sure.
where it lands with potential
Super.
bariatric surgery diversion and things
Yeah.
like that.
Yeah, good. Jeff, you have a question or a comment?
Yes. Well, as with most of our discussions this morning, all roads lead to engagement. And while there's huge potential for a lot of participants, somehow I'm not worried about having too many. I think how do we get a meaningful group to participate?
Yeah. Important comment. Any other?
Any ideas? Is there a response from our consultants to that question?
Jeff, we talk a lot about engagement, and we have a colleague, Erin Ward. I don't know if you've had the opportunity to meet Erin Ward yet. She's doing other work for OEB staff on the communication side, and we've been talking to her as well, you know, for creative ideas to help bridge this messaging. It's almost like a little bit of a game of telephone where we message to the school districts who message to the members, and how to work through that most effectively. Um, I don't have the answer for you today, other than I think we all recognize it's a priority, and maybe the methods that we've currently been relying on so far aren't enough. And so, what are other new ways that we can approach engagement for all of our programs, existing ones and new ones?
I think the other, this is Sarah. I think the other thing I'd add too is, you know, this program might be unique in that the GLP-1 drugs, as Dr. Chuang mentioned, these have taken a little bit of a life of their own. People are very interested in accessing this treatment. And so to the extent you can bundle access to these drugs for weight loss with this more comprehensive solution, I think in some ways that's going to draw people in because they're interested in the treatment and the medications.
Yeah, agreed. And the catch is, Jeff, if you just offered the drug, thousands would be using it, because it's another one of these, you know, boy, simple solution to a complex problem. The issue of getting people engaged is another issue. Okay, we are 5 minutes over time, and I have to, if that is the end of the presentation, I will thank Mercer for a very energetic and enlightening morning. And I think we've come up with some, early on, we got the business that we needed to get done, and we're laying out a lot of work in the future for us to do. Any other comment from SEOW members? Rose, do we have any a public comment?
No, Tom, you don't.
Okay, thank you.
You're welcome.
So any other, otherwise, if no other comment, we'll move our conversation.
Hey,
Some of our
Tom,
conversation.
Jeff has his
Yeah.
hand up.
Well, I think that was from before. I think he forgot to. He took care of it.
Sorry.
My
Sorry to
bad.
Yeah,
interrupt.
good. That's right. So with that, we're going to end the February SEOW meeting. We'll move the conversation that we had today to the board meeting later today. So I'll see you all in a bit.
Thanks, Tom. Thanks everyone for your time.
Goodbye, all.
Thank you.